are going to be talking about the cardiovascular system for the next several lectures. And so we're going to talk today about the heart, and then we're going to also discuss blood flow through the heart. And then on Wednesday, we're going to talk about conductivity and how the heart actually is able to beat. And then next week, we'll start off on Monday talking about blood pressure. And then after that, we'll go into the respiratory system. Okay, so you know that the heart sits in the thoracic cavity, and it sits basically in the middle, which is the mediastinum, and that the heart is supposed to point down to the left side of the body. So that when you take your stethoscope and you put it on somebody's chest, you're basically putting it on the left side to listen to the heartbeat. And this is what is referred to as a left axis deviation. Okay? However, one of the things you're going to find is that sometime in your career, when you put that stethoscope on the left side, you're going to find nothing. You're not going to hear the heart beating. So since they're alive sitting there, you probably just want to put the stethoscope on the right side, because sometimes people can actually have what's referred to as a right axis deviation, which means the heart is actually pushed to the right side. Now, this is usually because the person has one of two things going on. One, they could be pregnant, okay? And because of that big old parasite inside of them growing and creating pressure in the abdomen, what it's doing is it has the ability in some people to actually create that pressure and push up on the thoracic cavity, and it kind of pushes the heart to the right side. Now, after they deliver, the heart quite often just bounces back and goes back to the left side. The other issue can be that your patient may be morbidly obese. And so because, same thing with being pregnant, the extra pressure in the abdominal cavity can have a tendency to move that heart to the right side. Now, once in a while, maybe not even in your career, but once in a while in people's career, they'll put the stethoscope on the left and they'll put the stethoscope on the right, and they still don't hear anything go directly to the middle. And so you have this central axis deviation going on. And typically, this is going to be your patient who's really, really tall. And because they're so tall, remember we talked about growth hormone before, growth hormone is not just affecting the height of the person. It's causing the internal organs to also become larger. And because those organs are becoming larger, and of course one of those organs is the heart, some of the connective tissue that helps to hold the heart in the thoracic cavity can actually rip. It can tear, and so the heart kind of dangles and hangs down in the middle, okay? And that was kind of hard because now the heart is sitting under the sternum, so it's a little bit more difficult to listen to those heart sounds. But you know, if you take your time, you can still do what needs to be done. One of the things I want to point out when you're looking at this picture in the overhead, okay, because the heart is moving to the left, and also keep in mind that in the fetal stage of development, the heart develops before the lungs. So the heart's pointing to the left, and the lungs are going to develop around the heart. And one of the things we see is on the left side, there's not quite as much room as on the right side. So the right side is going to have 3 lobes to the lungs that are developing. The left side is only going to have 2 lobes. Okay, so the development on the right and left is just a little bit different. And then notice right underneath here, this is the diaphragm. So when we get into respiration, we're going to talk about the lungs and how it's attached to the diaphragm and attached to the thoracic cage and all that kind of stuff. All right, so we're going to talk today mainly about blood flow. And you know from your anatomy class that you learned that the heart has 4 chambers to it, okay? And as we go through this, we're going to talk about these different chambers and how the blood moves and the timing of that movement of blood, okay? So I'm going to draw the Dr. Harvey special when it comes to the heart. So here you go, my Valentine's heart. Lopsided, but that's okay. And you know the heart has the 4 chambers, okay? Now, when we're doing this, I want you to remember you're looking at your patient's right and your patient's left, Okay? So this is going to be the left side, and this is going to be the right side of the heart. Okay? Now, going into the heart on the right side, we have two major blood vessels. And these blood vessels are bringing blood into this first chamber. Now, what's the chamber called?
Atrium.
The atrium, okay? And the lower chambers are the ventricles. Very good. And what's this large vessel coming into the right atrium? Do you remember?
Superior vena cava.
Superior vena cava. Excellent. And so this one is the inferior vena cava. Okay, now, the blood that's coming into the right side, if it's coming in through the superior vena cava, this is blood that just was circulating through the body above the heart, and it's coming back to the heart. If the blood is coming through the inferior vena cava, this blood just passed through the areas of the body below the heart, and it's coming back to the heart. This blood is also what we would refer to as deoxygenated blood. Okay, so let's take a second and talk about oxygenated and deoxygenated. So you know inside every red blood cell is hemoglobin. And each red blood cell has about 1 million hemoglobin molecules. And one of the things that you learned early on is that hemoglobin is made out of 4 proteins, which makes it a quaternary structure, right? Okay? So if we look at a hemoglobin molecule, it's got these 4 proteins. And each of these proteins are referred to as a globin. Okay, that's the official name of each of the proteins. These are globin proteins. Now, in the middle of these proteins, there is an iron-containing chemical. And this iron-containing chemical is attached to the globin, and this is what we refer to as heme. Now, in biology, if you want to make a new word, you take 2 words, stick an O in between, voila, you have a new word. So we're going to take heme, O, globin. Okay, so that's where this comes from. Now, iron loves to bond to oxygen. So when blood moves through the lungs, the iron and the oxygen are going to be able to bond to each other. So you have oxygen that bonds to the heme portion only of our hemoglobin molecule. Now, because in each hemoglobin molecule you have 4 iron, if 1 oxygen is attached to this iron, we say that the hemoglobin molecule is 25% saturated. If we have 2 oxygen attached to the hemoglobin molecule, we say it is 50% saturated. If there's 3 oxygen attached to the iron, it's 75% saturated. If there's 4 oxygen, it's 100% saturated. Now, the reason this is important is because when you're working in the hospitals, one of the things you're going to be looking at are the O2 sats for your patient, the oxygen saturation, okay? And so, now keep in mind, 1 hemoglobin molecule can be 25, 50, 75, 100% saturated. But you have 1 million hemoglobin molecule per red blood cell, and you have millions of red blood cells, which is why sometimes you'll read a patient's saturation, their O2 sat is 68%. That means some of your hemoglobin molecules could be 50% saturated, some of them 75, others 25%, and all together, with all the hemoglobin molecules in all the red blood cells, the average is about 68%. Does that make sense? Now, this blood that's coming back to the right side of the heart, this is somewhere around 60 to 80% saturated with oxygen. Usually, if it's below 80%, the person's probably been working out a lot, or maybe they're sickly or something like that. But typically, somewhere around, let's say 80% is pretty normal. this blood has already circulated through the body, dropped off its oxygen supply to the tissues so that the tissues can make ATP, and then it's headed back to the heart, so the heart can then pump it to the lungs and pump it back out to the body. And when it goes back out to the body, it should be 100% saturated. Okay? Does that make sense? Any questions about any of that? That's a lot of information to throw at you all of a sudden. Good? Okay. Once this deoxygenated blood enters into the heart, it's going to go directly down into the ventricle. And there's an opening between the atria and the ventricles, and that blood just flows straight to the ventricle just simply by gravity. Okay? Now, you also know that between the atria and the ventricles, there are these valves. Okay? And so you've got an interesting setup. First, you have this valve that kind of hangs down into the ventricle while the blood is flowing. And can you remember what the name of this valve is? Tricuspid valve. Very good. Or what else could we call this? The right atrioventricular valve. That's its other fancy name. So this valve is naturally open, and because it's open, blood is going to flow straight on through and start filling up the ventricle. However, if you remember, there's some fancy stuff going on with this valve, and you have these little tiny muscles here on each side. Oh, I forgot to do this. Hold on. I was going to show you one thing, so I'll show you now. Just to kind of show you, this is muscle, or what we would call myocardium, okay, making up the walls of the heart. And on the left side of the heart, the myocardium is much thicker than on the right side of the heart. We'll get back to the valve in just a second. I just wanted to refresh your memory about that. Why is the left side of the heart needing a thicker layer of muscle than the right side?
Because of the body.
Yeah, because the right side only needs to pump the blood to the lungs, which is right next door. So it only has to be, wimpy, little tiny squeeze. But the left side has to be able to pump the blood all the way to your toes, out to your fingers, throughout the whole body. So it's be able to get a really tough, hard squeeze. So if you're wondering what side of the heart is the right or the left, you always look for the thickness of the muscle inside, and that will help you. Now, attached to this myocardium, or this cardiac muscle, are these other little muscles that come off the wall here. And what are those muscles called? Do you remember? Starts with a P. These are the papillary muscles. And then attached to those papillary muscles, and also attached to the underside of your valve, are these cord-like structures made out of connective tissue. Do you remember what those cords are called? Almost, a little bit backwards. Chordae tendineae. So good. All right, that's pretty good recall from anatomy. Oh, good job. Okay, now, why do we have this valve set up like it is? Okay, so now imagine you have this atrium and blood is flowing directly down into the ventricle. And the ventricle is filling up with blood. And if you could imagine, my hands are like the valves kind of hanging down into the ventricle. As that ventricle starts to fill up with blood, one of the things that's going to happen is the valves are going to start to be pushed up because of that blood. So again, the valves are hanging down and the blood's starting to fill up underneath, and the blood is going to start pushing the valves upward so that the valves start to close. However, right before that tricuspid valve closes, what we're going to see is we're going to see the atrial muscle contract. Now, somebody was looking at the heart one day and said, oh, a heart kind of looks like an upside down triangle, okay? And so this would be the base of the triangle, this would be the apex of the triangle, okay? So they said, all right, so this is the apex of the heart, and this we're going to call the base of the heart. Now that's important for you to know because when I describe this, you'll get what I mean. The atrial muscle is going to contract in a very particular pattern. What it's going to do is it's going to start at the base and it's going to contract downward towards the apex. Because the whole idea is all that blood's coming in the atrium and I want to squeeze as much blood out of the atrium and into the ventricle as possible so that I can fill that ventricle completely full of blood. Now here's the other interesting thing. As the ventricle is filling with blood and the valve is starting to shut, right before the valve shuts, the atrium contracts downward. And it contracts downward with such force that it pushes the blood into the ventricle, kind of like splashes in there, you might say, and fills the ventricle up so that the valves all of a sudden close and they snap shut. Now that snapping shut is going to become important, so keep that in mind as we talk. Once the atria contracts, the ventricle fills up and the valves snap shut. The heart is very quiet. The valve is closed, there's no blood flow, there's no muscle contracting. Now it only lasts for a couple of milliseconds, but this is a very important time in the heart, and this is what we refer to as diastole. So this is the quiet time of the heart. So, diastole is the quiet time. There's no blood flow through the heart. All the valves are closed, and the muscle is not contracting. Okay, so just kind of keep that in mind, because that's like a great exam question. What is diastole? You probably have to pick all of the above, but okay, there you go. Now, as soon as diastole is over, and again, it only lasts for a couple of milliseconds. Now the whole idea is we've filled up this ventricle. The valve is closed, the ventricle is full, and I need to get this deoxygenated blood to the lungs in order to add more oxygen. So there is a very nice vessel that's found in the right ventricle that's going to go out of the heart to carry the blood to the lungs. So now while this vessel is inside the heart, we call this the pulmonary trunk. When the vessel leaves the heart, what do we call it then? The pulmonary arteries or pulmonary veins? These are the pulmonary arteries because they carry blood away from the heart, or do we carry blood to the heart? Which is it with arteries? Away. Very good. Excellent. Thought I would get you on that one. All right, so let's pretend these are my lungs here. And so these are my pulmonary arteries. So I have a left pulmonary artery, I have a right pulmonary artery, and they're eventually going to carry the blood to the lungs so that I can oxygenate the blood. Okay, so now, a couple of things going on. First, right after diastole happens, the ventricle is going to contract. And because we want the blood to go up the pulmonary trunk and out the pulmonary arteries to the lungs, we need to push the blood upward. So the ventricle is going to contract from the apex up towards the base. And when the ventricle contracts up towards the base, that is going to push the blood upward through my pulmonary trunk and out the pulmonary arteries. And eventually, it's going to end up in the lungs, and I'm going to add oxygen. Any questions? Okay, now there's a couple of other issues that you should be familiar with here. And that has to do with the valve. Now, of course, the valve is shut as the ventricle starts to squeeze. And as that ventricular muscle squeezes, it's creating pressure. And it's pushing the blood upward. Now, we want it to just go up the pulmonary trunk. But what's to stop that valve from blowing backward if the blood is being pushed up by the ventricle? Theoretically, couldn't the valve just blow backwards? I mean, what do you think? Is it possible? Or is that valve made of titanium and there's no way it can blow backwards? Yeah, it blows backwards all the time. By the way, that's what we call a heart murmur, or sometimes you also refer to it as regurgitation, okay? And that's an issue. It's not supposed to happen. This is bad, because if this valve blows backwards, blood may not even be able to go up the pulmonary trunk. You may not be able to get any blood going to the lungs. That's not a good thing. Your valve has failed. So once that valve closes, you need it to stay closed. Okay, so let me give you an example. Let's say you have some crazy person who likes to jump, out of airplanes at 20,000 feet above the ground, where if they fall, they go splat. I don't know, it just doesn't like turning on. Not something I really want to do. But when they do, hopefully they do it with a well-packed parachute that's going to work for them, right? Why does the parachute work? I mean, they jumped out of an airplane and they're falling. Why does the parachute not just go psh and blow back? Kind of like, think about in the high desert, it's raining, you have an umbrella. Is the wind ever calm during that time? Oh, heck no. The wind's going to blow, and it's going to blow your umbrella backwards. And then you're going to get soaking wet, because that's just what happens in the high desert. Okay? So why does this person's parachute not blow back like your umbrella? Because that wind is strong as they're falling, just like the wind is strong up here. Why do they not die? What is it about the parachute that saves them? Think about it. Imagine a person with a parachute.
The shape of it, and maybe there's also like air vents to allow some of the air to go through.
Okay, and both of those are correct. That's correct. What else? There's something else that's real important.
The strings connecting it to the backpack that force it to keep it safe.
That connects to the person, right?
Yeah.
So you've got strings on the underside of that chute that connects to the individual. And it keeps the parachute in the right shape instead of blowing backwards. But what if I cut all those strings while the person was falling? What would happen? That's it. The parachute would go blowing in the wind and the person would go splat, right? Okay, now think about this. Think about the valve. When it closes, it's like the parachute. And all these chordae tendineae, these are like those strings that attach to the person. Except in this case, the person is the papillary muscles. So now I have my valve that's shut. And as the ventricular muscle is squeezing the blood upward, the papillary muscles also contract and pull the chordae tendineae downward. Okay? So now the ventricular muscle is squeezing and pushing the blood up, which is causing my valve to go up. And if I didn't have the chordae tendineae that was pulling my valve back down, my valve would blow backwards. And instead of the blood just going up the pulmonary trunk and out to the lungs, my blood is just going to go back and forth between the atria and the ventricle. And if it's bad enough, my person could die. So you see how important making sure not only that the valve closes, but that it stays closed and I don't get that blowback or that regurgitation. Any questions about that? Ever known somebody who has heart murmur? So think about this just for a second. Let's pretend that you know somebody that has a heart murmur. What would you think maybe some of their symptoms would be? If their valve isn't held tight, closed, it blows back. It regurgitates blood. What would some of their symptoms be maybe?
Low energy.
Low energy, absolutely. That's a big one because we're not getting the blood to the lungs like we should, which means we can't drop off the oxygen in the body. We can't make ATP. That's a really big one. And sometimes that's the first way that they know that this is an issue. What else might be a bit of a symptom?
And breathe at night.
Yes, they can have some difficulties breathing. And especially at nighttime seems to be a big issue for them. Okay? But yeah. And you know, some children are born with valves that are not completely formed. And so they might have like a little bit of blowback because the valve doesn't completely close. So like right along the edges of the valve, it's a little bit weak. And a lot of times those kids, their valves will develop over the next 5, maybe up to 10 years, so they don't have to have surgery or anything like that. And you never notice that they have any type of murmur problem until they want to play in sports. And so they're playing really hard, and then you notice that your child has purple lips, or they're really, really tired, and they don't have the energy that everybody else has, because when they're exercising or they're playing soccer or whatever it is they're doing, the heart is squeezing harder, more often, and it causes more pressure on that valve. And it doesn't close nearly as well. And it's really simple. They just have to sit down, rest for a little bit, and then they're typically okay after that.
So would they have like a blood pressure issue too, like a higher or lower?
Not normally. You don't really see too much of a blood pressure issue. It's usually just a lack of oxygen issue. Yeah.
Would high blood pressure make their situation worse?
Yes, absolutely. Yeah. And now in adults, it can be a genetic problem. So it may be a valve that never totally grew. Or here's another one. So a heart attack is basically not enough oxygen to the muscle of the heart. And so that muscle tissue dies. Well, some of that muscle are papillary muscles. So when people have heart attacks, they can actually have heart attacks of the papillary muscles. And sometimes those papillary muscles will even explode. And if there's no papillary muscles, there's no pulling the cords down. There's no way. Do you smell smoke?
Oh, there's like a fire over by, it's a little Kingston.
Oh, okay. I just wanted to make sure it wasn't here. Okay, that's all. Anyway, so the papillary muscles, if they can't pull the cords down, they can't keep the valve closed. Okay? All right, so now, once the blood has gone out to the lungs, it's going to come back to the heart by way of the pulmonary veins. Now you have 2 pulmonary veins coming back to the left atrium of the heart from each of the lungs. And I'm not going to draw it over there, I'm just going to say there's 2 openings here. And this time, we have oxygenated blood. By the way, when a red blood cell moves through the lungs, it can move through the lungs as fast as 1/4 of a second, which is really interesting because in 1/4 of a second, that red blood cell has to be able to pick up 1 million hemoglobin molecules. So there is some seriously fast diffusion going on, putting that oxygen into the red blood cell. In any case, on the left side, we have the same setup that we have on the right side. We have a valve, and that valve is attached to papillary muscles by way of the chordae tendineae. What's the name of the valve on the left side of the heart? That's the bicuspid, yep. Or we could call this the left atrioventricular valve, or what's its third name? The mitral valve, very good. So in the hospital, the weird thing is typically on the right side, they'll call it the right AV valve, but on the left side, they'll call it the mitral valve. So you just need to know all the names because who knows what they're going to call it. I think it's kind of interesting because somebody looked at this valve one day and they said, oh, we're going to call this the mitral valve because it looks like the Pope's hat. Have you ever seen that white hat the Pope wears? I don't know. So it's that his hat's called a mitre hat, so they called that the mitral valve. I don't know, whatever, weird. Okay, so now that oxygenated blood is going to go right into the ventricle as soon as it hits the atrium because that valve is naturally going to be open and simply by gravity it's moving into the ventricle of the heart. And as this ventricle fills up, we're going to see the same thing happen. The blood is going to push on the underside of the valve, causing the valve to move all the way up. But before the valve completely closes, the left atrium is going to contract downward, squeezing the last little bits of blood into the ventricle, filling the ventricle up and pushing on the valve so that the valve snaps shut. And we're in diastole again. That quiet time where the valve is closed, no blood is flowing, there's no contraction of the muscle. And after those couple of milliseconds, we're going to see the blood being pushed out of another major vessel that takes the blood out to the body. What is this major vessel? It starts with an A. The aorta. Very good. So in order to do that, we need the ventricle to contract. At the same time the ventricle is contracting, the papillary muscles are going to contract. So the ventricle is going to squeeze from the apex up towards the base. We're going to squeeze the blood upward, but the papillary muscles are going to contract and pull the cords downward. As the ventricle squeezes upward, the valves are being pulled downward by the chordae tendineae, and they stay shut. And that allows all of this oxygenated blood to flow up the aorta and out to the systemic circulation, or out to the body as a whole. Another term you should know is systole. Systole is ventricular contraction. Okay, so now you already know, even though we've explained it as the right side contracting and then the left side contracts, you already know that that's not how the heart works. You know they're both sides, right and left, are contracting together. Okay, so let's just kind of go over that one time. So while the blood is coming into the right side of the heart through the superior and inferior vena cava, that deoxygenated blood, at the same time, at the same rate, even the same amount of blood is coming from the lungs through the pulmonary arteries or veins. What are those that come from the lungs? These are the pulmonary veins. I forgot to label that. So let me just do that right now. Just so that you keep it in your picture of what it is, okay? So again, blood is coming through the superior and inferior vena cava to the right atrium at the same time, at the same rate, the same amount, equal amounts of blood are coming from the lungs through the pulmonary veins to the left atrium. Which also means the right and left AV valves are wide open and blood is flowing directly into the ventricles. The ventricles are filling up and both the right and left AV valves are closing at the same rate. And right before those valves close, the right and left atria are going to contract downward, squeeze the last little bits of blood into the ventricle, and that will cause both the right and left AV valves to snap shut at the same time. And then all the valves are closed, the blood is not flowing, the heart is not contracting, you're in diastole for the next couple of milliseconds. After that, we're going to go into systole. Both the right and left ventricle are going to contract upwards, from the apex up towards the base. At the same time, the papillary muscles are pulling the valves downward to keep them closed, and the blood is going to flow out the pulmonary trunk to the lungs. At the same time, it's flowing out the aorta to the body. Now, I want to stress to you that the amount of blood that's coming into the right side is the same amount that comes into the left side. How's that possible? Well, where did the blood from the left side originally come from?
The right side.
Came from the right side. Very good. Came from the right side. So, however much blood you fill up the right side, it will eventually end up on the left side. So it's always the same amount. And if it's not the same amount, something's wrong. Okay? There's something seriously wrong here. You want the right and the left side to always have the same amount of blood. And you want the rate of both sides filling to also be the same. Now, you do also know that there is a little valve in the aorta, and there's a little valve in the pulmonary trunk. You remember those? You have the pulmonary semilunar valve and the aortic semilunar valve. We'll drop semilunar. We don't ever say that. That's just something they teach you in anatomy. This is the aortic valve, and this is the pulmonic valve. You're never going to use semilunar when you work in the doctor's office. Just not going to happen. These valves are naturally closed. They're only going to open up when blood pushes against them. So it's like you kind of pushing a door open, blood is going to push these valves open. So when the blood is going up the aorta and going up the pulmonary trunk, what it's doing as it's coming up is it's going to cause the valves to pop open. Okay? Now, the way that the blood goes out the pulmonary trunk and out the aorta, there's a little bit of a curve. So there's never enough force, when you squeeze the ventricle, there's never enough force to get every drop of blood over that curve. So there's going to be a little bit of blood flowing back down the pulmonary trunk, and a little bit of blood flowing back down the aorta. And when it does, it'll get caught in the little, what they call cusps, the little C shapes or half moon shapes of the valve. The blood gets caught in this and causes the valve to close. And when it closes, it snaps shut. Now, the reason I've stressed the AV valves close together, and when they close, they snap shut. The aortic and the pulmonary valve, when they close together and they snap shut. The reason I'm stressing this is because this is what you're listening to when you use a stethoscope. You're listening to the valves shutting. So you hear that boom boom sound, or they also call it lub dub, okay? The first sound are the AV valves snapping shut. The second sound are the semilunar valves snapping shut. So what if you heard this instead of boom boom? What if you heard bubba bubba boom, bubba bubba boom, bubba bubba boom, bubba bubba boom? What is this telling you?
They're not shutting up.
They're all shutting at a different time, aren't they? They're not shutting together. What does that do to the person's blood flow through the heart if every valve is shutting at a different time than a different valve?
Molecularly, the same.
Yeah, it's not going to be the same.
The same amount of blood.
Well, okay, in the right and left side, potentially, yes. You could have different amounts into each side, absolutely. And that's because it's start, stop type of blood flow. And you don't want that. A matter of fact, we call that an S4 gallop, and that is not what you want to hear when you put the stethoscope to your patient's heart. Now, if you have a patient who has a heart murmur, that means their AV valve, some AV valve, usually it's the left side that goes, okay? But it could be the right side too. But the left side typically goes, so it's not snapping shut with the other. So when you're listening with your stethoscope, a heart murmur sounds like a whoosh, whoosh, whoosh. because the blood is flowing backwards. The valve's not shutting with that snap sound, that boom sound. You hear this whoosh type of sound. Any questions about this so far? Nothing? We're good? Okay. Trying to think. Oh, so let's just talk for a minute about somebody having a heart murmur and valve replacement. Okay? So it's kind of interesting. When they first started doing these surgeries and wanting to do valve replacement, they're trying to figure out, what do we replace the valve with? Well, somebody came up with a great idea. How about taking the valve from an animal and putting that valve into the human heart? Would this work? Well, it turns out it works really, really well. Okay, so then the next question is, which animal could we get our hands on? And there's plenty of them. That also has hearts similar to humans. Well, interestingly enough, it turns out to be a pig, okay? So we slaughter pigs all the time to have bacon, and there's all those pig hearts. So they said, hey, we just want the valves from those hearts. And so they started transplanting into humans these pig valves. Okay, that's great. But somebody didn't do their homework, because how long does a pig live? What's your best guess? How long does a pig live? Yeah, that's a pretty good guess. Around 8 to 10 years. Okay, if you just let the pig grow old and die. Around 8 to 10 years. Well, what's a pig die from most often if you let them grow old and die? Heart failure. Okay? This is an issue. So now you have these poor patients, okay, who have to go through open heart surgery. And one of the things you have to do, and this is the worst part of the whole surgery, is you have to saw through their sternum, and then you take retractors and you pull their ribs inside out, which also means you might break them, or you might crack them off of the spinal cord, and there's a lot of terrible things that can happen. And then you fix their heart. And now when they wake up, they've got a bunch of broken bones too. Ow, okay? And now you're gonna give them a pig valve that you have to replace about every 5 years. Most of your patients are gonna go, that's okay, I'd rather die. Because that is an extremely painful thing to go through. My father had to have 5 open heart surgeries. And after the 5th one, he said, not again. I cannot do this, I cannot recuperate from this. And he would have rather died. So it's very painful for your patients. So, okay, let's try to figure out something else that's gonna kind of last a little bit longer. Okay, came up with a great idea. Let's take some pieces of plastic, and we'll sew these pieces of plastic in, and then these pieces of plastic can open and close like a valve. Great idea. Except, again, nobody tested this before they put it in a person, and when they put it in, the plastic smoothly opened and closed. So when you put a stethoscope up against their chest, you couldn't hear those valves, so you didn't know if they were working or not. Well, shoot, this is a problem. Okay, hold on, I got an idea. Here's how we're gonna fix it, and this is what they did. They put a little BB in here, so that when it opened and closed, it made a clicking sound. Well, again, oops, we didn't test it before we put this in the human. And you know, your heart is beating 72, 80 times per minute, and that BB is going clink, 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 and the human could hear it. It drove some of them insane, literally. Okay? Maybe you should test these things before you put them in humans. Okay, so now the pig thing isn't working, this valve isn't working, what the heck do we do? And it just so happens that there was a cardiologist who was totally into muscle cars, and my father was a mechanic, so you probably will not understand this, but he worked on Holley 4-barrel carburetors, which are just a beautiful thing that makes cars go really fast and not have a need for speed, okay? So I love Holley 4-barrel carburetors, and there's this really nice valve on this carburetor, which is what helps to move your gas through your car, by the way, in case you don't know. And the valve is what we call a butterfly valve, and it opens and closes, and every time it closes, it goes click, click, click. And the cardiologist went, oh, I just found the valve. So they made it out of a really nice plastic, and they put these types of butterfly valves into humans. Now, by the way, they tested them in sheep and goats to make sure that they could hear it with a stethoscope. Somebody used their brains first, okay? And now those valves will last longer than the human. The valves will be there like 200 years after the human dies. So they work beautifully. And once a person has to have a valve replacement, that's never going to need to be replaced again. It's a very rare occurrence if they need another one, which, whew, that's a good thing.